Afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's session is Colorado Transparency in Healthcare Prices Act goes into effect in January 2018. Are you ready? We are scheduled to run for 60 minutes for today's presentation, but before we get started, I would like to review a few housekeeping notes. I would like to welcome two guests for today's presentation, Jonathan Wiik and Annie McCollough. Jonathan brings over 20 years experience to healthcare, serving in acute care, insurance, and business solution settings. Jonathan is an officer on the Colorado HFMA board and president of the board of directors at an assisted living facility. As an active advocate of legislative changes to evolve the healthcare industry, Jonathan recently authored Healthcare Revolution: The Patient is the New Payer, and has spoken at numerous national and state events. Jonathan is principal of Revenue Cycle Management Healthcare Solutions with TransUnion. I also like to welcome Annie McCollough, who's shareholder at Pulsanelli and has nearly 30 years of health law experience. Her healthcare practice focuses on operational aspects of hospitals and other healthcare providers, including regulatory compliance, hospital physician financial arrangements, medical staff, health facility licensure, medical enrollment, EMTALA, and government investigations. Among other recognitions, Anne was named by the best lawyers in America for health law in 2009 through 2018, and Denver Healthcare Law Lawyer of the Year of 2017. So very experienced group here. So without further delay, I'd like to hand the call over to our guest presenters. Jonathan, I think you're up first.
I am, and thank you so much for kicking off, and hello to my Colorado friends out there. Learning objectives today that Ann and I will go over is really want to give you kind of a market footprint. I'll take that piece of what's happening both in Colorado and nationally from a transparency standpoint. Transparency I refer to kind of as a unicorn. Everyone can describe it, but no one's ever really seen one. And so I want to talk through what those pieces look like. Anne will do a wonderful part. I've seen her slides of the requirements of the bill specifically and things to watch out for and how to meet compliance. And then we'll look at some approaches and just how to implement this at your organization, because this bill does go into effect for the first of the year. So we can dive into this market overview here. So I always like starting with a cartoon. So, there's a lemonade stand and he's selling it at $500 a glass. He says, well, when your price is high, people assume your product must be very good. I've actually seen studies where some patients that do shop will pick the one that is more expensive because they think that hospital might have a higher quality or safety rating, even though it may not even be there. There's maybe one that's $1,000 or one that's $800, but they pick the $1,000 ones because it's their health and they want what's best. And I don't know that lemonade should cost $500, but maybe that should say, aspirin, for our pharmaceutical stuff. But nonetheless, that's my cartoon. So I did take this a step further. This is a national health expenditure study. It's fascinating stuff. But if you take the inflation rate of common goods and apply them to things that you buy at the grocery store, they would have inflated at the rates you see here. A dozen eggs would be $55. A gallon of milk is just under $50, and a dozen oranges are $145. I can tell most of you on the phone will be like, I would never, ever pay that at the grocery store, but you're paying it in healthcare, and healthcare costs have just dramatically gone up. And part of the reason is that the prices haven't been out there and as transparent as they needed to be, or they've been somewhat shadowed or phantomed by the employers or government payment of those services. So patients had their portion that they paid, and didn't see the rest of it in the insured market. And self-pay patients may have gotten charity or some sort of very deep discount, but these prices slowly creeped up over the last 20 to 30 years. And we don't have $55 eggs, but we certainly have, $1,200 MRIs and $45,000 surgeries and $200,000 inpatient stays and $5,000 emergency room visits. And so we're here. It's not groceries, it's healthcare. I get it, but the costs have risen dramatically over the past decade. They've risen so much over the past decade that you could see how the cost shifting has gone over to patients here. So there's been a 63% increase in deductibles since 2011 that has outpaced inflation and earnings. I don't think any of us got a 63% raise, but we certainly got a 63% increase in our deductibles. They have quadrupled from 2003. They are up to $2,100 now, and the percent of workers that have a deductible, which means when they come in and access services they do not have first dollar coverage, has surpassed the 80% mark, and it is now at 83%. And this is a Kaiser Family Foundation report. Awesome resource if you ever want to find out what's going on. Health Pocket does a study and releases what the average deductibles are for the ACA or Obamacare plans each year. These are actually the 2018 rates, I apologize. Looked them up earlier this week. And they did go up. I also, trended them. I thought that would be interesting for the group to look at from when the ACA and health exchange plans first came onto the market and what those deductibles look like today. On the bronze and silver plans, the government pushes you to a silver plan, and the brokers will as well. They don't really want you on the bronzes, but there's quite a high adoption there. The silver plans have seen a 40% increase in their deductibles, and it's now at $4,000, almost double what you saw in the commercial market on the slide before. Bronze is approaching very close to $6,000, and on the gold and platinum plans, we've seen either a flat or reduction. So another way of looking at this slide is the people that can least afford insurance have had the most increase in their deductible. So I'm really worried for the ACA plans. As you know on the phone, the cost sharing reductions did not go in, and so the premiums are likely going to increase, and I think that's going to make this transparency legislation and approach become very, very important in your hospital's operations as you look at patients that will come to you that are either having a higher out-of-pocket share or they are self-pay. When I was working in a hospital, a deductible that was in the $2,000 to $4,000 to $5,000 range, that basically was a self-pay patient. Consumers, frankly, don't have that level of liquidity in their income for unexpected expenses, and so we had to go through very similar exercises with high deductibles as we did with charity to make sure that patients were not, having financial troubles as well as health troubles while they were there. This is causing big problems, for families. I love these numbers. This comes from the National Center for Health Statistics. But 1 in 4 patients have a bill that's not paid right now, and I'm one of those 4. I've got one in my briefcase. I'm going to try to pay on my way to the airport. 1 in 5 are paying a bill over time, and 1 in 10 have a bill of some sort that they'll never pay at all. This is very scary. I mean, you could start saying that 10 to 20% of the country have medical bills that they're either not going to pay or going to have to pay them a very long over time. And so having transparency out there with funding mechanisms established is very important, and that's what part of the bill spirit is getting at, is trying to understand how patients can understand what these financial liabilities are in advance of care. More woes. I won't go too much into detail just in the interest of time. This is a Commonwealth study, but these are all the bad things that happen to good people because of a medical bill. Across the bottom axis there, you can see their credit score got impacted. They lost their savings. They took on more credit card debt. They took out a mortgage, or they had to declare bankruptcy. One of these times when I present, I won't say that medical bills are the #1 cause of bankruptcy, but they still are, gang, and it's really troubling. One thing that is interesting on this is if you notice the colors in here, blue are people that had insurance, orange are the underinsured, that's by a Commonwealth definition, and then red are ones that had no insurance at all. The close correlation and even sometimes surpassing of folks, some folks actually had worse or had less things that were bad happen to them by not having insurance at all than ones that did, because these deductibles and things that are out there are creating a false sense of coverage, and they're creating medical debt. Next slide. So is this bill good for Colorado? Well, I did a little bit of research, and I said, if we applied it to something very simple, most people know what an MRI is. This is a study that was done. This comes from the Kaiser family as well, a very trusted resource. They said when patients were notified, and I think that's key, when patients were notified of a less expensive MRI option, there was an average savings of about 19%, or $220. I did some rough math. You know, it's hard to find out. You'd be amazed how hard it is to find out how many MRIs were performed. But let's just say 30 million were. That's $664 million in savings. And I think anybody would like to save that. I think consumers want to shop when you ask them, but they don't. And the next slide will get at that. I have a slide later that gets to that. I'm sorry. Transparency, by definition, this is the GAO definition, is the availability of provider-specific information on specific health services or to consumers of their complete health care costs. And that has these three factors. Negotiated discounts is inclusive of all the costs, not just the facility fees, but the supplies and the physician fees and things like that, the readouts. And then most importantly, what we'll talk about a lot today is what the consumer's out-of-pocket costs are, or self-pay costs. You sometimes hear that term, and we'll get into that in her section on what that means. HFMA's got some really great resources out there. You're all HFMA members or no one, or you wouldn't be here. HFMA's got an awesome document out there that they've created. It's a price transparency booklet, and in there I pulled some excerpts out. And it's a free resource to HFMA members, but it says readily available information on the price of healthcare services. That, together with other information, helps define the value of those services and enables patients and other care purchasers to identify, compare, and choose provider that offer the desired level of value. One thing that you may or may not know is almost every payer in our country has a portal. You may have known that. I would love if we had some poll questions to understand, maybe we can get to it in the Q&A, of how many folks have actually gone to that portal to go look at it. Because Blue Cross Blue Shield, Cigna, United, Anthem, you name it, they all have a portal where you can punch up your plan, punch up where you're going, type in the codes and take a look and see what those prices are. But the fact is most folks just go to the doc and do what they're told, because it's a very unique and sporadic experience, right? We don't frequent the physician, most of us don't. It's usually for something unexpected. And so that's when the pricing and costs come up, and I think the insurance is kind of the last stop on that train, not the first. CMS, I went out at Ann's suggestion, and I love that she suggested it. I went out to the CMS website just to see what they're up to. They have an open request for information now, which I think is great. They're looking to fund through grants transparency innovations, and this is the excerpt from there. And the goal of this grant would be to better inform consumers about the cost and quality implications of different choices. And CMS wants to develop models to facilitate and encourage price and quality transparency, including analysis and release of that data across, and they're going to consider options. The web links down there at the bottom, fascinating study. I encourage those of you on the phone that are looking at to go look at that. And I think we get legislation, as Ann will tell you, because nothing's happening. So if we can innovate this as an industry ourselves, the government wouldn't have to step in and help us out with that. So this is a way of getting at that. So they're saying, hey, let's see if we can get some innovation from the hospital space to help people understand what cost and quality look like from our providers. Right now, a little over half the states in our country have at least one law related to transparency. Colorado there in the middle has had 3 in its inception, and Florida, no surprise, and California, both very high utilization of healthcare states, have 6. You can kind of see how they're spread around, but a little over half of the United States has transparency bills. So these aren't new to us here in Colorado. Most of the country fails in meeting the standards. Yay for Colorado, we're that A in the middle. Us and Virginia and Maine were the only state, New Hampshire and Maine were the only states to receive an A. I'll get to how this got scored in a minute, but basically this is, hey, you know, if you're going to have a transparent program in your state or as a facility, how are you meeting that mark for consumers? Are you using an all claims payer database? Are you breaking down what those discounts look like? Are the bills, or are charges coming across? Is it easy to navigate? Can folks get in there and share and understand the data in an easy way? That gets you an A. It's very, very troubling that 43% or 43 of our states failed, according to this Catalyst study from the Healthcare Innovations Task Force. That study is an awesome one to look at if you want to become like a transparency guru. It's really great, that link at the bottom of the slide. This is the scoring. So the folks that scored high, as I mentioned, had an all-payer claims database. They had hospitals, facilities, and clinicians involved. They showed the amount that were paid, not that were charged. They had a full scope of services, both in the ambulatory and acute care space. The data was very public and very easy to access. You can see that's a pretty high bar that they've set, but I think that's what most consumers these days want, is they want to be able to get this information and look at it, and it's extremely difficult to pull this information out because we've got a very complex reimbursement system in our country. Next slide, Ann. So this is just a footprint of all the payer databases. There's 11 states that have them. Colorado, of course, is one of them. 5 are implementing, and there's some others. You know, I don't know that Civic, I believe, is our all claims payer dates in Colorado. It has some procedures, not all, but nonetheless, it's an all-payer claims database, and so it allows folks to go in there and kind of look and see, as a consumer, what the average price is for very common procedures. 42 state report hospital charges and make that information available to the public. This high cost of care, as I've mentioned, has generated a public outcry. This has been followed by legislative action, and adoption of patient engagement to these sites is poor, and it's rarely referenced. And I think we're going to get into, you know, why that is here in just a minute. Okay, here's that JAMA study that I alluded to earlier. So the journal JAMA came out and they did this really cool study, and the link's down there below, where they took a sample of patients who had a large sample of patients who had a high deductible health plan, and they took a sample of patients that didn't have a high deductible health plan, and they surveyed them and said, hey, did you call the doc before you went or not? Did you shop for care before you went? They asked them about 10 questions. But they found what's underlying here, that only 1% of difference was between the two groups that had a high deductible or not. So the fact of the matter is, as much transparency legislation that's out there, I don't know that patients access it much. I think they do what their physicians and their family and their friends tell them. The data, having it out there, certainly would help from a patient financial engagement standpoint, and it certainly would help have a much more streamlined and operational and satisfactory payment thing versus having an envelope come in the mail. Those things are all there. And I think hospitals and providers, my point with this slide, are going to have a pull strategy, not a push strategy, and simply publishing prices or out-of-pocket costs aren't going to really get there. You got to have a financial engagement strategy with your patients to have them understand that cost, the coverage they have, and how they're going to pay that bill over time, because most of it's unaffordable out of the gate. The other point that JAMA made is that you hear a lot about the deductibles and how they can save costs, because patients are in the driver's seat in terms of how they're picking and choosing care based off quality and cost, where in fact JAMA pointed out that most of the savings is because once they knew what the deductible was, they were so scared of how high it was, they didn't go at all. So it actually was a savings in utilization or not getting the care versus picking a low-cost provider. Next up, yeah. And so I'm going to turn it over here to Ann, and she's going to walk you through the elements of the bill.
And Jonathan will be back for our Q&A portion of the presentation. So switching over to Colorado law, I want to talk about kind of two high-level themes. First off is, how do providers, facilities, healthcare systems comply with this new law? And then secondly, how is this new law really advancing this theme that we talked about with transparency? How do customers actually get kind of meaningful comparisons among providers? So the basics of the Transparency in Healthcare Prices Act is that healthcare facilities and providers have to publish what I'm calling kind of the self-pay prices, for healthcare services for a certain number of common healthcare services. So it's kind of a narrow statute. But let's talk initially about what's not covered in this Transparency in Healthcare Prices Act. This act doesn't address a number of the elements that Jonathan was talking about in his part of the presentation. It doesn't talk about negotiated healthcare insurance rates. It doesn't talk about insured patient out-of-pocket expenses. It doesn't talk about, for example, those high ACA for the copayments and deductibles. There's no quality data. It doesn't address charity policies, and it doesn't address some of the elements that some of you might be familiar with in the Colorado Hospital Association. This is different from, and in addition to, the requirements under the Affordable Public, there's standard charges, slightly different definition than what we have, I think, here for healthcare prices under Colorado law. So be aware that this is a different law with some different requirements for your healthcare systems. And again, under the ACA, there was a little bit more leeway. There was some leeway. You could make a list available or have a process for members of the public to review your list in response to an inquiry. So let's dive in a little bit on this law. What we're going to be talking about are kind of the who, what, and where under this law, because this affects a broad range of their facilities, and each has its own obligations under the law. And I'm going to try to point out for you, particularly for those of you who work with or are part of a healthcare system, where some of the gaps in the statute, I think, have come up for a real integrated healthcare system. So the law divides the obligations into both healthcare providers and healthcare facilities. So we're going to kind of tackle healthcare providers first. Obviously, under the healthcare providers, the obligation really falls to the individual licensed or certified healthcare provider to have these prices available. But there's some availability if a healthcare provider is affiliated with a group or a PC or an IPA to have the prices be displayed by those groups. But I think with the definition under the Act, it's not clear what happens with, for example, it's not clear what happens if a hospital has, like a hospital-owned clinic that's really organized under the exception to the corporate practice of medicine as a provider network. What happens with those entities? We can talk about this a little bit more under facilities also, but I'm going to posit that because the obligation to display your prices, the healthcare prices, is on the individual practitioner, that if exceptions or is employed by a provider network which isn't completely addressed under the statute, that there's still an obligation under the law to display the healthcare point of your, if you're that the obligation to display these prices to make this information available on a website probably still applies to those individuals and could probably be addressed by the provider network. I would be inclined to take the position that a provider network is really a quote-unquote medical group as defined under this Act that has the obligation then to make this pricing information available. So how is the healthcare provider supposed to make these healthcare providers? The healthcare providers have to have what's called a single document it's supposed to look like. It doesn't tell us much about what the how one displays this electronically, if not through the website. But the content of the document is much more narrow than what we're going to see for facilities. It's the 15 most common healthcare services, either by CPT code or some other coding system, and a description of the healthcare service in plain English. Now, one thing that I didn't put in my slides but I should probably mention is that the healthcare services do include telemedicine. And with this burgeoning telemedicine market here in Colorado and elsewhere, this is for Colorado entities. You would have to somehow display also the pricing for your telemedicine services. There are a number kind of nuances. As this bill evolved, a lot of nuances were put into place. One of the nuances is that if it's a solo healthcare provider or fewer than 6 providers in a group, they can make the healthcare prices available in the waiting areas, as opposed to having some kind of an electronic document or posting it on a website. You can post it in the patient waiting area in your practice. Wouldn't work very well for telemedicine, but it's an option for kind of a traditional standalone solo practice or small physician group practice. There's another exception for healthcare providers who are members of a PC that contracts with a single HMO. I kind of look at this as kind of the Kaiser type exception. Under those circumstances, the individual healthcare provider can rely on the HMO's posting of the healthcare prices for self-pay patients. The last exemption on this slide, I think it's a little troubling, and maybe that's not the right word, but it's a little concerning for me, because I think over the years, if you've been watching some of the concerns for patients with out-of-network pricing, with patients who show up with no insurance and get hit with bills that push them into bankruptcy, sometimes a lot of that relates to hospital-based healthcare providers, emergency department physicians, for example, anesthesia. If there are no controls on what these physicians provide, if they have an exclusive contract with the hospital, for example, and they're not governed by any limitations on their pricing. This exemption for hospital-based healthcare providers only applies if the physicians are not employees of the hospital. So the Act really doesn't tell us then if they are employees of the hospital and are hospital-based physicians, then is it an individual obligation to post the prices on a website? How would a physician get access to that website? Or can you argue that the group, for example, the group of employed ED physicians is indeed a quote-unquote medical group as defined under the Act? These questions really aren't answered under the Act, but I think that, again, if you look at the purpose of the Act, which is to promote transparency, and the obligation of providers that falls on the individual provider, someone, either the individual provider or the provider's employer, should be making sure that this information is available to the public, probably on the hospital's website. So if you haven't thought that nuance through, I'm putting that out there for you. We're going to talk about pricing a little bit later because that applies both for providers and for facilities. But when you're making these disclosures, when a provider or provider group is making these disclosures on their website or in their waiting area, they should disclose that the healthcare prices are estimates and actual costs depend upon the circumstances. And obviously that's for the protection of the patient, and it's also for the protection of the provider, so that they don't get caught in having to abide by a posted price when the patient's actual cost of care was significantly higher or lower. The healthcare provider has to make a very specific disclosure, substantially similar to what I've put up there. I'm not going to read it to you, but it really kind of gets at 2 paths. One, if the patient's insured, they should call their health insurer, and then if they're not insured, they should call the billing office because the posted prices might not reflect the actual amount of the patient's individual financial responsibility. So you don't have to follow this exact text, but this is what the Act suggests. And when we get to the end of the slides, I'm going to make some other suggestions for disclosures that providers and healthcare facilities might want to consider. So now we're going to switch over to healthcare facilities a little bit, and this is pretty broad. This law has very broad application to healthcare facilities. Facilities licensed or certified by the CDPHE with certain narrow exclusions for nursing care, assisted living, and home health agencies. So this is going to capture and require pricing data from hospitals, ASCs, community clinics with emergency centers, what we call the CCECs, dialysis, hospice, and it's a little hard to know how some of these entities, based on their reimbursement, will comply with this disclosure obligation. So As with healthcare providers, the healthcare facilities are obligated to disclose healthcare prices in a single document, either electronically or on the website. There's no alternative for healthcare facilities to post it in a waiting room, and that's kind of for obvious reasons. So what do you have to display? You have to display for the patients your 50 most used DRGs or codes for inpatient, 25 most used for outpatient CPT codes or other codes, and what they call kind of a description of the healthcare service in plain English. And that makes sense because, again, this is all intended to promote transparency for the patients. So if a patient is looking up prices, not that you shop in advance for this, but if they want to know the price for a myocardial infarction, you probably are going to put a parentheses heart attack. Or if they want to know what the price is for cerebral artery occlusion with infarction, you might want to say stroke. So the patients know what they are. This little exception to the 50 DRGs and 25 CPT codes, though, for healthcare facilities, I think is going to be very helpful for smaller entities, like maybe a critical access hospital that has maybe 20, 25 common DRGs. So if inpatient DRG, for example, is used fewer than 25 times in 12 months, you don't have to post it. The critical access hospital would only post the 25 most common DRGs that have been used more than 11 or more times in a particular 12-month period. As with healthcare providers, the healthcare facility, again, discloses that the prices are estimates, and the actual costs depend upon the circumstances. It's like the mirror, you know, the objects in your mirror, maybe closer than they appear in the mirror. And then a specific statement that, again, is very, very similar to what we just discussed for the healthcare providers. Again, referring the patients, if they're insured, back to their health insurance company. And if they're not insured, then to call the billing office. And again, because of the caveat that the prices that a healthcare facility posts might not be the actual financial responsibility of the individual patient. So now we're going to get to some of the meat, and I think where a lot of the confusion and difficulty comes up in this law is what's meant by healthcare price. I'm not a financial expert. I'm an attorney, but we're going to walk this through, and I'm guessing there might be some questions on this as we go forward. But the healthcare prices for providers and facilities, I think, again, think this through a little bit from the perspective of the self-pay patient, whether the self-pay patient is rich, poor without insurance, or a young invincible who didn't get insurance through the ACA. There are a number of circumstances that lead people to be self-pay patients, but that's kind of the focus of this law. So the healthcare price, again, is before negotiating any discounts for third-party payers, discounts for anybody else. It's the charge, and it's not what the patient is going to actually pay, but it's what you're going to charge the patient for these particular healthcare services, for the particular healthcare diagnosis. But it doesn't include the amounts for complications or exceptional treatments. If you look at some of the pricing data that's out there, a lot of the pricing data might say a particular diagnosis, like a vaginal delivery without complications and then a vaginal delivery with complications. So the postings that you make for this particular law are not supposed to include amounts for complications. And here's where I think those of you who are financial experts in the room are going to be spending a lot of your time. This strikes me as a very labor-intensive process to try to pull together these prices. The good news is that as this law was negotiated through the legislature, there was a lot of flexibility built into the law. So that's good for the providers, for the healthcare facilities, in that you can pick one of these options to calculate your healthcare prices, but you can also come up with another way of calculating your healthcare prices. So that's kind of good for you in that, good for our healthcare clients in that they have some flexibility in defining what their healthcare prices. But I'll posit that I think it's bad for transparency because it's going to make it very hard for individual consumers to actually be able to compare apples to apples across healthcare providers. Because if you think it's hard for you to figure out how to price this stuff and what the pricing mechanisms should be and how to understand them, imagine the perspective of a self-pay customer trying to decide where to get their gallbladder taken out and how to compare the prices. If every hospital or ASC is going to use kind of a different methodology for calculating and describing their healthcare prices. And I'll just briefly, obviously these are the price charged most frequently, 12 months, highest charge from the lowest half of charges in the 12 months, and then a range, the middle 50th percentile. At least when I've kind of looked at what some facilities have been doing, I mostly see a range that describes a range of healthcare prices. But again, my recommendation, we talked about the disclosures a little earlier on, is that if you pick one of these three options or have a slightly different variation on the option for your version of price transparency, I would suggest that you say how you reach the prices, so that because that will enhance transparency and it'll avoid confusion if the patients say, well, I don't like your methodology because look at what you actually charged me. Another comment on the disclosures is that I think when you're putting up these prices, I do think it's important to share with the members of the public what's not included. For example, that big nugget for hospitals, that big nugget of the hospital-based physicians is not included in this pricing. The cost of the surgeon is not included in this pricing. So I think that's another element to make these more clear for the consumers and to avoid issues down the road for the healthcare facilities. A little more clarity that was in the statute on healthcare price doesn't mean the amount charged if a public or private healthcare party will be paying or reimbursing. Public and private healthcare party is defined very, very broadly to include obviously health insurance and company health insurers, HMOs, TPAs on behalf of employers. So it's a very broad bucket of exclusion from the definition of healthcare price. On this next slide, I think, again, this is part of what I was saying about the disclosures, that if when you're making these healthcare pricing disclosures, is to include as much information and disclaimers written in plain English that you think is appropriate. And the law says you may disclose the basis for your healthcare prices, and I would suggest that you do, so that the consumers, it would enhance the transparency so they at least have an ability to understand, oh, that's a range, and you did the range of the 50th percentile, the mid-50th percentile. This last clause, though, I found a little confusing because it says you may take into consideration all payer services when determining a healthcare price. And I think the only way I can really reconcile that clause in the statute for facilities against the definitions of healthcare prices is that what they're talking about are charges, not negotiated discounts. But again, I found that to be a little ambiguous and a little confusing under the statute. So I'm going to share with you kind of some of the good news under this act, because I think that's all pretty confusing about what you're supposed to do and the deadlines come upon you. Some of the good news in all of this act is that you don't have to report your pricing. You don't have to get the CDPHE's approval for your pricing list. You don't have to, you're not going to be faced with the CDPHE second-guessing your pricing list and making you change your pricing list. This is really kind of a soft enforcement, soft to no enforcement under this law. And the law itself is really intended to to give some flexibility. And what the law says is that it's supposed to be free from paperwork. And if any of you in the financial finance departments of your healthcare facilities are probably saying, I have a lot of paperwork for this, thank you very much. But I think what they're trying to say is that there's no paperwork that has to be submitted to an agency. They say that there's no punishment. They define punishment as no penalties, surcharges, fees, or costs from the participation under this act. And finally, this last little bullet says that healthcare pricing shall not be used as a basis for determining payment rates from a public or private third party for that healthcare service. These are publicly available documents. Everyone's going to be looking at them. And one of the thoughts that's come to my mind when you think about this published data is I think come January 1st, I think all healthcare facilities in Colorado should expect that there's going to be a very big article published somewhere that compares all of your data. So it's something to be aware of because of the data is available. So even if the statute itself says no punishment, that doesn't mean no public shaming or no public disclosure of healthcare pricing. So I think at the end of the day, I think these healthcare pricing decisions, how you compile the information, how you display the information, how you calculate the healthcare pricing is going to be largely a business decision, not so much a legal issue, but a business decision for each of your healthcare facilities to think about. And again, kind of back to our friend, the customer, think about the end user of this information because it's again, you're in a very sophisticated area. Healthcare pricing is incredibly complicated. So how is this information going to be available to and used by the self-pay patients who might be trying to do a price comparison to get their knee fixed, to get their ankle fixed, to get their gallbladder taken out if it's not an emergency? So again, plain English, give good explanations. And I think on your displays, again, you get a lot of opportunities to put disclaimers on your websites. I think the biggest disclaimer of all is please call us. Please call us and ask your questions. We are here to help you. We are here to help you understand this data. We want to work with you on these issues. So I'm hoping that Jonathan was able to join us again. Are you on the line, Jonathan?
I am here, if you can hear me.
We can hear you just fine. So Jonathan and I then kind of wanted to go for a little bit through some of the kind of what's next and what we would suggest to the healthcare providers, the healthcare facilities in the community. And our first bullet is get busy. But I'm assuming that most of you are busy on this, and you are working on this. And I think that this is going to be an ongoing process for health as you see what other providers are doing, as you maybe reach out to the community. Jonathan, I didn't know if you wanted to talk about running the healthcare pricing report with a few methodologies, if you have any thoughts on that, or if you'd like me to speak to that.
Yeah, I think the report will be important to kind of just run it, see where you're at, and how hard it is to run that report. Where it's going, kind of the mechanics of it. I think that's going to be 80% of the work here. And as Ann eloquently put, how you're determining those charges and if there's math involved once the report's extracted out of your, your charge master and those types of things or whatever that manipulation may be. And then I think, educate, we'll get to this later, but it's going to be important to understand, who is doing it, where they're doing it, when they're doing it, kind of getting at that as if it was just a new task added to someone's list and kind of inventorying that in your workflow.
There are some resources available for those of the HFMA members who are also Colorado Hospital Association members. So as you're thinking this through and how it's going to work and what might be best practices, I encourage you to reach out to HFMA, reach out to other trade associations, because I think there are going to be resources out there because you're not alone. You're not going to be the only company that's trying to address these issues. I do think there ought to be an owner for the healthcare pricing so that someone really is on top of this and is monitoring this. The Act does require an updating at least annually, but it can be more frequently than once each year. Because I'm imagining that for a lot of healthcare facilities, they're going to put this up, they're going to put it out their finance department. Is going to work with some patients here and there and see how it's working, see what the feedback is, see if they think it's clear enough, see if they think that their methodology has been sufficiently clear for the patient to understand, or if they want to improve their methodology over time. And in terms of the disclosures, we talked about that a little bit already, but I do think, again, I would tie a lot of this in with the disclosures of your charity care policy, if you want to put up your prompt pay discount policy, if you have one. But again, I think the key, I think, to making this transparency process work is to really encourage the patients to dialogue with the healthcare facility, dialogue with the healthcare providers. Jonathan, what else do you have?
I just think that, with any new piece of legislation, there's a learning curve, and I think the state will understand that, and the Department of Health and Human Services will understand that. But that's a double-edged sword, right? As we saw some bills passed last year in our state, they're quickly followed by, "Hey, how's it going? Are you doing stuff with it? Are you, we saw that with 501R as well. Did you update your charity policies?" They're, doing IRS on as well. So I think you can't sit and assume nothing's going to happen. This is law, and so it means you have to take action and put this team together like Ann described, and really document where you're going to do and when you're going to do it, and make sure that when folks are calling in external to the organization, that those lines are known and that process is known. Because the worst thing you'd want to have happen is someone from the state or the Department of Health and Human Services or a Public Health and Environment call and say, "Hey, your charges aren't posted." "Oh, we didn't want to do it." Someone answers on the phone or something. That would be bad. So you want to make sure that your team knows what's going on, and you've got a process in place on where those calls go and where the documents store.
And this is Danny. Just one more comment, and then maybe we can take some questions if Nikki has any questions in the queue. Is that right now, again, the law doesn't require you to report, doesn't give CDPAT oversight, gives health facilities and healthcare providers a lot of flexibility in terms of how they're going to do their pricing and how they're going to calculate and display the pricing. But I could see over time, if the legislature does and the CDPAT feel as though the industry itself is not really responding to this law, is not really promoting transparency for patients in the community, then we might see through the legislature a more mandatory process that does have sanctions and teeth attached.
Oh boy.
Great stuff, guys. I tell you, thank you, Jonathan, and it's such a great collaborative effort, and strategic and practical guidance is something that our audience always crave. And there have been a couple questions that have popped up. Some of them actually you addressed as you got further into the presentation, so apologies if I call out a question that has already been covered. But the first thing I would like to address is questions around copies of the slides. So no need to wait. You can get access to those slides right now. Just look to the right of your screen. You'll see a section called Handouts. Expand that and you'll see that PDF icon. So feel free to download those right away. And let's see here. Let's look at some of these questions. Here's another one that came in very early in the call. And it just reads, what challenges do you see with displaying charges for this bill?
Go ahead, Ann.
Sorry, was the word challenges, Nikki?
What challenges do you see with displaying charges for this bill?
Boy, and Jonathan, jump in at any time, but I think the challenges are to select a methodology, to calculate on the methodology, and to display on the methodology, and in a way that's going to be that's going to promote transparency for your patients. And when the patients get a bill that's different from what was posted on your website, I think that's going to create some real challenges, I think, for healthcare providers and healthcare facilities. So I think a lot of it gets down to this healthcare pricing methodology. And again, that's part of why I think one way to do an end run around the confusion and around the likelihood that patients will be very, very confused is to really try to promote dialogue with the patients on a one-on-one basis to the extent that you can. Jonathan,
yeah, I agree with Dan. Yeah, I completely agree. I think, it's you could envision at the hospital level almost, I don't know that you need a policy formally written, but certainly a procedure that says, we're going to respond to this bill by, and, we're going to assign an owner, we're going to, and kind of write it down, because as we all know, people change hands, and as laws, are in place, the understanding of what they were when they were passed versus what they are a couple of years from now can get somewhat fuzzy. So I agree with Ann that I think that's going to be some challenges to understand what the methodology is, document what methodology you used, and who was in charge of that, those types of things. I don't think the challenge, and I think the reconciliation piece that Ann mentioned is huge. The worst thing you ever want to do is get into some sort of price war or discrepancy war with the patient. So that methodology needs to be repeatable and known by the staff that are administering it, so that when questions come in, patients are getting similar answers. I don't know if they're going to be the same all the time, but they should be close.
Very good. Thank you for both of you for that. This next question comes from Suzanne, and she wants to know, it's a couple small questions in here just to clarify, but she's asked, does this apply to a community health center at the 15 code provider level, or is this just medical, not dental? What about physical therapy, behavioral health?
This is Annie. I can take some of those questions. I'm not a coding person. This does apply to medical, mental health, dental, optometry, and hospitalization. So it does apply broadly. A healthcare facility does include any facility that's licensed or certified. So if the question was about the licensed community clinic, what we call the CC, that sometimes has the CCEC, the Community Clinic and Emergency Center licensure category under the CDPHE, it does apply to those entities.
Perfect. All right. Our next one is from Lori, and it reads, the Senate bill states non-negotiated rates. The CHA document on pricing transparency states self-pay rates. Can we post charges that are discounted by your self-pay discount?
I'm not sure I'm clear on what CHA document this is referring to. This is what you're supposed to be posting is, again, non-discounted rates. But if you have charges, and for every single self-pay patient who ever walks in the door, you apply the same discount, my guess would be that would be your charge, and that could be the price that's displayed. And I hope I'm understanding the question correctly, but that's my reaction. So hopefully that gives you enough flexibility.
Yeah, I'd add, Ann, that I think that's going to be where rubber hits the road with stuff, right? Where are you gonna where's that price coming from, and what's that methodology? I think if I were to put an auditor hat on, which isn't happening in this case, but if someone was looking at it externally, I guess I'll put it that way, what was the methodology used, and is it following the documentation that you said you do it? So if your business decision is to display a self-pay discount fee schedule, which is based off the same algorithm like Ann said across all of your charges, say that, and then post it that way, and then make sure everybody knows that's where it came from, and that meets the spirit of the legislation in terms of promoting transparency from that regard.
Perfect. And then just a very quick follow-up to that, Suzanne mentioned that CHCs are usually considered non-facility providers, so that's why she thinks that we fall under the provider rules with a 15 code requirement. And she was wondering, could you provide any insight in who she could contact at the state level for clarification? Is there a particular role?
Can you read that again? I'm just having a little problem with the hearing you. What kind of facilities are you referring to, please?
So CHCs, she says, are usually considered non-facility providers. So she thinks that that's why they fall under the provider rules for a 15 code requirement. So she's questioning, is there anyone at her state level that she can reach out to for clarification?
Yeah, I think I'm tracking much better now. Yeah, I think that's probably right. That those are gonna be considered providers. And again, I think that's probably one of the gaps in the legislation where they're not licensed. They're not licensed facilities under CDPHE, but they do have healthcare providers. For example, physicians, maybe mental health providers, and I think that would probably, again, there's some ambiguity under the statute, but I think that you can reach out to the CDPHE, see if they have any insight into that. But I think that a safe way to make sure that the individual healthcare providers' mandate to publish their prices is taken care of is either to publish the individual providers' schedules, or if there's an argument that the CHC is a medical group or an IPA or one of these other groups, to kind of to then pool all of the 15 codes for the people within the clinic. And that's a question that I don't think I can answer right now, but I think I appreciate her pointing out this another ambiguity under the Act.
Awesome, thanks for that. I think we may have time for one more quick question. Let's see here. Let's pull this one in from Pilar. It reads, is there a threshold limit for reporting? Meaning, if the most common CPT is for a VIN puncher and costs only $15, making it a minimal financial impactful service, will it be forced to be included?
Boy, that's a good question. I think the answer is yes. There's no de minimis exception under this Act for minor procedures or healthcare services that are performed. It's probably just something that wasn't really thought through because it really focuses on the more common healthcare services and not the more expensive.
Gotcha. All right. So perfect. I know there are a couple other questions out there that we did not get a chance to address. I'm happy to send those over to the chapter and the presenters so they can look at those individual questions. We really appreciate all of the submissions that did come in. Just so I'm mindful of time, we're going to go ahead and wrap it up. So I would like to thank Jonathan and Annie for a great presentation. Thank you for taking time out of your schedule to prepare the presentation. I know how much of a bear that can be, so thank you to both of you.
Thank you.
Oh, absolutely. As you exit, you will be automatically routed to a survey, so please share your thoughts and be sure to provide the email addresses of everyone in the room so everyone can receive proper credit. And then on behalf of HFMA Region 10, I'd like to thank everybody for joining today's call, and we hope to see you online in the future. Have a great afternoon, everyone.
Bye.
Thank you, everyone.